Welcome to the Moxie OT podcast, where we invite occupational therapy practitioners, consumers, and friends of OT to talk about evidence-based practice. Today we'll be talking to Laura Hayes, an occupational therapist who specializes in the treatment of low vision. I know many of us are uncomfortable when addressing low vision, but it's a diagnosis that OTs need to address in almost any setting. Let's meet Laura. All right, today on the Moxie OT podcast, we'll be talking with Laura Hayes about OT's role in the treatment of low vision. Laura is an OT and works at the Chicago Lighthouse Low Vision Clinic and is a contract OT at the Illinois Eye Institute Low Vision Clinic. Laura and I are acquainted through friend of the podcast, Matt Klinger, and while I'm always happy to talk OT with Laura, I also know she's a great problem solver in escape rooms. Laura, thanks so much for joining us today on the Moxie OT podcast.
Thank you. I'm so happy to be here and looking forward to our conversation.
Yeah, we're really excited to have you here too, because I know when I ask clinicians what areas of practice they're most uncomfortable with, vision almost always comes up. It's an area of practice that does get covered in OT school, but maybe not to the depth that most of us would prefer. Can you tell us a little bit about your background and how you came to specialize in low vision?
Absolutely. It's a good place to jump off in our conversation. So I'm actually will be celebrating my 10-year anniversary this April and working at the Chicago Lighthouse. So working full time in the low vision field. So it's a big one, a decade.
Congratulations.
Thank you. And I mean, just to kind of go before that, I did complete my occupational therapy, a master's degree at Boston University. And then I actually went directly into my position with the Chicago Lighthouse after I graduated, which I know can be maybe a little bit non-traditional to sort of move into a more specialized area so early on, but it was one of those things where things just aligned in a way and I decided to go for it. I didn't really know I was going to do anything with low vision while I was in school. I did know I liked working with adults across the lifespan. I did know I liked working kind of in a more outpatient or home-based setting. And then I remember just in like our didactic education, all the coursework on low vision, even though it was minimal, it definitely piqued my interest. Just thinking, gosh, like there's so much interplay between somebody having a vision impairment and what they're really able to do in their day-to-day life. And I just felt like it was an area that is just so well suited for an occupational therapist. And then the opportunity of the position came up and the timing was right. So I went for it. And to kind of comment on, I think for people that might feel uncomfortable with low vision, I think a big piece of it is hopefully you having a mentor. And that's what I had at the Lighthouse. I had really wonderful mentorship through Hillary Napier-Gondek, and she's an OT in the Chicago area. She's now actually moved to academia and is over at DePaul. They're starting an occupational therapy program. But she was the OT that really trained me when I started out. And a combination of her training, and then I just had to throw myself into additional learning. So just trying to learn everything I could. I relied heavily on Mary Warren's book, The OT Interventions for Adults with Low Vision. That was my go-to book at the time. I also relied a lot on, there's a great website called visionaware.org, and that's a great one if you're looking to just learn a little bit more about low vision and tips and strategies. So I would go on there and read things. And then I also was able to attend the Envision conference really early on when I had started at the Lighthouse. And for those who might not know that conference, it's a multidisciplinary conference on vision rehabilitation. So it's pretty great. It's got ophthalmologists, optometrists, occupational therapists, mobility specialists, all in one place talking about vision rehabilitation. So that was a great way to learn more.
Yeah, I think those are all great tips for both new graduates that are maybe wanting to enter a specialized area early in their career, or even, a lot of us wonder, like, can I really make a career change? They always say in OT you can change, settings, but it feels like a big leap sometimes. So I think that thinking about like, well, can I find a mentor, whether it's at this this site where I'm getting a job, or, reaching out into the OT community, and what are the other resources that I can really dive into?
Mhm.
Super
Absolutely.
helpful. So you are the associate director of OT at the Chicago Lighthouse, and which is, I'm going to start that over.
Mhm.
So you are the associate director of OT at the Okay, one more time. So you are the associate director of OT at the Chicago Lighthouse Low Vision Clinic, which is a social services agency for people with vision impairments, and your contract OT at the Illinois Eye Institute Low Vision Clinic. Are these the typical settings that OT practitioners address low vision in?
Yeah, I would say that that is a pretty common one, especially for OTs who are working full time in low vision. So, I mean, that's what I do every day. I don't really have other components to the position. Whereas you might see low vision positions at a hospital, for example, or or a rehabilitation hospital, where there might be an OT that specializes in vision, but they may be splitting some of their time kind of in other areas as well, potentially. You could also see OTs doing low vision in a more pediatric setting. So, I mean, there are OTs in schools that may specialize more in low vision or visual impairments, as well as I know home health agencies sometimes will offer kind of specialized low vision services through their organization. So you might see sort of an OT there that may be the one with the skill set that knows the most about low vision doing that as well. Uh, I think what's really nice about the Lighthouse is that because we're an organization that's really focused on vision rehabilitation, it's very comprehensive. And so I have a lot of vision resources that are really available to me in-house, so to speak. And that's wonderful because I really can rely on my other colleagues for different things. And so at the Lighthouse, for example, we have low vision optometrists who are performing the initial eye exams with individuals. We have the OT department. We have an assistive technology department. We have a psychologist on staff. We have a store, a retail store, which is actually housed right next to the clinic, which is great because I do recommend a lot of equipment and things. And it's nice to be able to just maybe walk over to the store and show them things and talk about how it might be helpful. So it's nice to sort of have that all there. It doesn't mean you can't do low vision without those things, but I think that's why you might see OTs like myself often in these settings, just because we have a lot of that sort of at our fingertips.
Hmm. I think so. As a person who's also worked as a clinician here in Chicago, I often, stepping back a minute, I often will talk to my students about how you really need to be prepared to address low vision in any setting, because we know that it's often a comorbidity with other diagnoses, that as people age, they're more likely to have macular degeneration or diabetic retinopathy. But then at the same time, I've also made those referrals to the Chicago Lighthouse to the Blind when somebody really could benefit from a lot of the resources that you have there. So I think it's kind of important to have OTs in both of those roles.
Absolutely. And it's something I try to take as many students as possible. And I'll tell them, even if maybe they're not seeing themselves going into exactly like a full-time position like mine, that I can guarantee they will see low vision wherever they end up. It truly, any setting, it could be in the community setting, mental health, hospitals, outpatient. It is very prevalent. And I said, this is going to give you a little bit more confidence to know how to navigate that, as well as be able to properly refer if that person needs more than maybe what you're able to offer with the equipment you have or the resources you have at that site.
Absolutely. And so I think that for some folks, like low vision, it does sound like this super specialized area of treatment that maybe they're trepidatious to enter. So maybe you could just talk to us about like what low vision therapy is, what kind of clients you work with.
Yeah, sure. I first want to start off, I think, with just defining what low vision is, because it helps to sort of set the tone for a lot of the things I'm going to be recommending. So, the definition of low vision is any visual impairment that cannot be corrected medically, surgically, or with any sort of conventional eyeglasses or magnification or optics. And so, something that's incredibly important to remember about visual impairments is that vision loss is really on a spectrum. spectrum. And over the years, I've noticed this when working with patients and clients, that what can be a point of frustration for them is that a lot of people don't understand that. So, for example, if they're wearing glasses, people will make an assumption that they're wearing glasses that they're fully corrected with and that they could then read everything. And that very much might not be the case. Many people with low vision do wear glasses and it can help some, but they still could theoretically be what's considered legally blind while wearing a pair of glasses. And so, if they ask for help, for example, like in a grocery store, sometimes people will ask why they're saying, please read this to me. They'll say, put your glasses on, or you have your glasses on. Why aren't you reading that? And that sort of disconnect of people not always understanding there's such a huge spectrum of vision losses out there is really important. And on the flip side, also not making an assumption if somebody says they're visually impaired, that that necessarily means they are profoundly visually impaired or blind. The vast majority really do fall into this more gray area where there's a lot of remaining residual vision. And so that's the bulk really of who I'm working with at the Lighthouse in terms of my patients. So moving to your question more about what is low vision therapy, that's defined as low vision therapy is working with individuals to utilize their remaining or available vision to accomplish whatever their valued tasks are in new and different ways. And so obviously that will depend. Some people may benefit from more optical intervention than somebody else, but we're really focusing on what is still remaining and how we can enhance that. And this can be everything from including training on use of optical devices, so using magnifiers or telescopes. High power reading glasses can certainly be helpful for people, sometimes prism glasses. I do a lot with home safety recommendations. So, making sure that somebody's able to do things, like get in and out of their shower safely, get on and off their toilet safely, be able to cook safely if that's a goal. Lighting is another huge area in low vision therapy. Lighting can be tremendously helpful for people with a vision impairment. But when I say that, also lighting can be done wrong. People can have glare sensitivities, or if lighting isn't positioned the way they want it, it also can actually make it worse. So providing that expertise on how we can really set up the lighting to meet their specific needs. Do a lot of like technology training. Talking about financial management might be another area in low vision. And then eccentric viewing is another big one that I may address as well. And what that is that's again focusing on trying to maximize a person's remaining vision. So for many macular degeneration patients, they have these blind spots, or they're called scotomas, in their vision. And so we can work with them to try to shift their eyes and actually use a different part of the retina to see a little bit better. And so that's another way that we can train them to get the most out of what they still have. And then I'd also say we do a lot of mobility, so home mobility and safety, talking about falls. That's another big piece of low vision therapy.
So
And then,
really,
you asked about sorry.
well, I was just going to say, like, you can see like how important OT is. And, when you're
Mhm.
talking about safety and falls and home management, financial management, those are
There's so much.
all those areas that we address with our clients. And
Exactly.
just because the impairment happens to be with their eyes doesn't mean that OT doesn't have a role there.
Mhm. Yeah. And I would say in terms of like the diagnoses that I see, just so people can get familiar with them, I work with a lot of people with age-related macular degeneration, glaucoma, diabetic retinopathy, also neurological vision loss that might come from a stroke. So hemianopsia, for example, or retinal vein occlusions. I work with people who've had vision loss from autoimmune disease, vision loss from a trauma. Inherited retinal diseases are out there, like retinitis pigmentosa, Stargardt's disease, corneal disease. So there are a lot of causes of vision loss, unfortunately. So, I really work with all of that. And I think that's also what makes it, though, I guess I could say exciting for me. It's not like going into a field where you're just working with like just a small handful of visual diagnoses. You really can see a breadth to that, which keeps you on your toes, keeps you learning, and 10 years in, I still sometimes see things on charts and I'm like, I haven't seen that before, or I've barely seen that. That's, good because that keeps you challenged, keeps you engaged, interested in what you're
Yeah.
doing.
Absolutely. And I think that's really interesting to hear because I think that maybe there are some folks out there who maybe didn't want to specialize because they like that variety. And so knowing that you can still be in a specialization, but know that there's still a lot of variety of diagnoses and different areas that you'll be working with the clients. And I think that's really helpful to hear. So what is you've tapped into this a little bit, but I'm just wondering if you could tell us a little bit more about what the focus of your interventions are.
Sure. So yeah, I said, again, we're not able to fully correct someone's vision. So the focus of what we're going to try to do is how can we help somebody to work with what their current vision is and navigate most likely progressive visual changes for a lot of people. And so we do that, in several means. And some of the primary guiding principles for me are teaching things like self-management skills and self-efficacy, um, through their vision loss, or teaching adaptations, teaching compensatory strategies, and making a lot of, modifications to things. And then another big piece I focus on is also we do need to establish new skills. And so there can be a fair amount of equipment that may be beneficial to somebody. As I had mentioned, some of the magnifiers and things. And most people are not proficient at, how to use a magnifier off the bat, of course. Who would be? And so that's a role as an OT in developing and establishing those new skills on how to use the equipment correctly, and so we don't have device abandonment where things are sitting in
Yeah.
drawers and not being utilized because no one spent the time really showing them how to use it. And then also going back to the eccentric viewing training, the maximizing of the remaining vision is another big area that we would focus on. But you won't see in low vision sort of a restorative um,
Right.
approach, just because that's not going to be realistic for patients with a visual impairment. And it's nice because I'm able to also deliver my services. I work in a clinic, but I also do go out into homes. And so I think that is a really nice piece of my position, because there's so much you can really see in a home, especially visually related. So when I talk about the modifications on all that, there's nothing like being in someone's home to
Yes.
really be able to just get in there and do what needs to be
Absolutely.
done and
That's
help
so
them.
exciting that you get to do that. And I talk so often on this show about how OTs, one of their really big strengths is being able to look at the context. And when you can go into someone's home and be like, wow, look at the glare at your kitchen table or whatever, that can be so helpful.
Yeah, absolutely.
Can you tell us a little bit about maybe what your evaluation process looks like?
hmm Yeah. So my evaluation, I do a combination of things, and it does depend on the patient and their visual diagnosis. I often am always going to do some kind of semi-structured interview occupational profile. So it's really important for me to get background on, obviously, what are they having difficulty with? What equipment maybe are they currently using? Learning about their environments, their support system, things like that. And then I also supplemented with an assessment called the Self-Report Assessment of Functional Visual Performance. It's a bit of a mouthful. And I do use, there's a revised measure, and it was created by Mary Warren. And it's available online. People can find it. And it's essentially an ADL assessment that has a greater focus on vision dependent ADL tasks. And it has gone through all the psychometrics in terms of being considered valid and reliable measure for older adults who have age-related vision loss. So I try to incorporate, as much as I can, obviously using evaluations that are validated and have gone through all the rigorous testing. So that's a one I'll use a lot as well. But on top of that, because I am doing an interview, and sometimes it is just sort of what that person is reporting they are able to do, or their perceived abilities. If I might feel, for example, potentially there could be a disconnect, or I'm not totally sure, I can certainly ask during the evaluation maybe to have them demonstrate something. So to give a more specific example, could be like a phone. If I'm asking about, what kind of phone are you using? Is it a cell phone, landline? How are you dialing? I might say, hey, why don't we pull out your cell phone? Can you show me how you might call your daughter or something like that? And that can also give me good information as to if the person is able to do that or not. So clinical observations are kind of implemented as needed through the interview and evaluation. I will also try to gather really good data on if they are using optical devices. So I will utilize a lot of standardized reading cards. So there are a lot of cards out there called the game card or the Feinbloom card that are essentially reading charts, so to speak. And I will maybe have that person read through what they can see as best they can using whatever glasses they're working with at the time, or maybe no glasses. And I make sure I record all that information, because then later on that can be something, maybe if I'm adding in a stronger pair of glasses or a magnifier, that's a way that we can, show the baseline and then show how they have progressed, hopefully. So a lot of my evaluation will be getting that data. And then neuro patients, I might use pieces of the BIVABA, which is the brain injury visual assessment battery for adults. They love having like mouthfuls for these.
They sure do.
uh, and I won't administer the whole thing. I don't really need to in my setting, simply because that person has been referred to me by one of our optometrists who's done actually a lot of that testing already. But I do use a lot of their scanning exercises. They have some wonderful
Yeah, those are my
scanning
favorite in
ones.
the
Yeah,
BIVABA.
it can give you so much valuable information about a hemianopsia or neglect, or what might be going on. So I use those quite a bit. Or the visual copy, drawing a diagram. I might also, sometimes I need to be sort of assessing for left neglect versus more of just a strict left field cut. Those are two different things. So we can do that through clock drawings, line bisections, always asking about falls in an evaluation, screening for depression. That's a big piece. There's a huge cognitive or mental health component, I should say, to dealing with vision loss. It's actually very, very prevalent. There's a lot of research on that. And then cognitive screening as well. I might implement a piece of that into my evaluation if that's important, or I think is needed. So that's kind of what an evaluation looks like.
That's
A
a
lot
lot,
there.
but I think it's another good example of how OT is so perfectly set for low vision, because we do have that mental health background and we do understand cognition, and being able to take all of those pieces together and treat the person holistically is such a great opportunity.
Mhm.
Um, so you've done your evaluation. You've told us a lot about some of the interventions that you use, but maybe you can tell us a little bit about what the process might look like, or how you might incorporate self-management into the process.
Yeah. So obviously, as any good OT, we do our evaluation, and then we, move from there in terms of what's important to our client, identifying those specific areas that we're going to now address in greater detail. I would say in general, with people with low vision, I do see a pretty heavy emphasis on IADLs in my treatment sessions. That's not to say ADLs are not included. I don't want to eliminate that, but a lot of times the IADLs need a lot of reading and things like that. And reading is so high up there as an area that's been often affected by a visual impairment. So focusing on reading, and then you think about writing, writing really involves reading, being able to see what you've written, reread what you've written. So that's very common to talk with somebody about. Cooking, mobility, medication management, those all might be more specific areas that I would delve into, and a lot of environmental stuff. So to maybe give an example, this week, this is a good one. This is somebody I saw this week in her home, and we went into her bathroom, and she's in a tub, and she's like, I've got all the grab bars, Laura, and I've got equipment. So I go and take a peek, and I realize when I go in there, everything is white.
Oh,
Like
yeah.
everything is white. It's like, the shower is tiled white, the grab bars are white. She has a bench, the bench is white, and then she has a rug, that she steps out onto, that's white floor. And the rug is like sliding around.
Oh my goodness,
And
nightmare.
yeah. So, we talked about, I said, you've got all, a lot of great stuff in here, but I think one thing that's going to really help is we have to improve the contrast, because everything is just blending together for you. And so maybe the first place we start is, since the rug already you have is not the one I would recommend, it just moves around too much. It really should have a grip to it and be just a lower profile rug, not one of those ones that sits really high. So I said, maybe we can swap that out and then also pick a rug that's going to contrast against your tub and your floor. So that is going to be more visual to you as you're getting in and out. You're going to be aware of it, more careful when you're stepping onto it. And then we talked a little bit more about the grab bars. And she said, Laura, honestly, where my vision's at, I can see the bars, even though they're white on the white. But she was, thinking, I think, future related, say, but what if that changes? What do I do then? It's hard to take those bars out. It's a big production. So I
Right.
said, maybe we just do something where you find a bright electrical tape. I know it's maybe not the most aesthetic thing, but wrap a little bit of that around that bar so it's going to pop out from the wall. And so that could be just one example of what I might do in a session with a patient, especially that's more like environmentally focused and drawing upon that principle of contrast, which is a big one in low vision.
Yeah. I think
So
that's a great
I,
example.
yeah. And I'd say like another example could be, and this also employing like the self-management technique would be an example with working with a patient who has glaucoma. And so, for those who might not know, glaucoma affects your optic nerve and it places pressure on that optic nerve. And as a result, can lead to a lot of peripheral vision loss the higher the pressure is. So, the vast majority of people who have glaucoma are taking some kind of eye drop, and they may be taking multiple eye drops multiple times a day. So it's a big deal, and it's really important because it can get the pressure under control and then hopefully prevent any more vision loss, which is critical. So that's always something that I'm asking about, is how are they doing with that eye drop installation? And a lot of times people struggle with it,
Sure.
understandably. It's hard to align the bottle. People miss a lot. People are wasting drops, and glaucoma drops are very expensive. So that is an issue itself. People, if they're going through their drops all the time, it's a financial cost to them, or they then become very dependent on somebody else to put the drops in, and that can be unreliable. And the drops really do need to be, the schedule is important and the timing is important. So how might I come in there and provide suggestions? And one would be maybe talking with them more about the auto drop. And it's a really low cost device. It's just a small little cup that basically a person could put the eye drop bottle into, and then it sits around the orbital bone, and it just aligns the tip of the bottle much better over their eye and can prevent some of the blinking and things that we often will want to do as we're
Sure.
anticipating putting in an eye drop. And so that's a way that we can, give that person a tool that will potentially allow them to be able to complete that activity more independently on their own, and and just make them feel more comfortable that I don't have to necessarily rely on them. Again, that builds into the self-efficacy, the more involvement that is so important with self-management, is really trying to be a direct participant in whatever is going on. And so that could be just another example of an
Yeah.
intervention that I might do.
That's such a essentially simple intervention, but like you were saying, can really increase somebody's independence if they're not having to make sure family's home to help them with their eye drops. And I love it. And it's a good example of I don't know, I might call that like a medium tech,
Mhm.
but I was wondering if you could tell us more about some of the technology. You've mentioned a few things, but there's so many resources for technology these days. What do
Yeah.
you incorporate?
Yeah. And that's a really fun area, especially when you've been somewhere for 10 years. Obviously it's amazing what technology can do, continues to do, and the growth. So I do a lot with more, I guess we could say, higher tech or just technology intervention. And that could look like anything from working with a person if they have a smartphone. So we do, there's a lot on Androids and iPhones and iPads and tablets with built-in accessibility, and some people really don't know it's there. And so it sometimes can be as simple as, let's go into your settings and increase the font. It can be more complicated than that, but that could be one example. Or maybe we switch your phone over to a reverse contrast and have a black background with white print. If the white is just glaring too much for your eyes. There's also magnifiers that are in smartphones that people can activate. There are screen readers, And then obviously, virtual assistants are huge. So using things like Siri and Alexa and OK Google on Androids, all of those things can be really helpful. So to go back to like a phone, I talked about that a little bit before. Maybe dialing the phone is not going to be possible for somebody because it's just too hard to see on the screen. It is totally smooth on a smartphone, and that can be challenging for people with a vision impairment. So we might switch over to getting more comfortable with using Siri and saying, Siri, call so and so. And that can be huge for people. It's very important that we can reach people more than ever, especially
Yes.
over the phone. And so that could be just an example of something that we might do. And then there's really a lot of like real high tech stuff, electronic magnifiers. There are wearable devices out there. There's a piece of equipment called OrCam, which essentially is a person would wear a pair of glasses and there's a camera mounted onto the glasses,
Oh,
and they
wow.
can tap on a paper or something, and then that takes a snapshot of it and then reads the material into the person's ear. So there's a
That's
lot of stuff
incredible.
out there. Yeah,
Yeah,
there's a ton of stuff.
that's so exciting to hear about some of the higher tech things. And then I think it's just, I don't know, for those of us that have been around for a little while, I remember when I had clients that just needed like pressure breaks, and I'd be like, well, you need to get a kitchen timer, or, and like when it dawned on me that I could start using their smartphones and set alarms, or that's something that I've worked on trying to feel more comfortable with, as far as like changing contrast or increasing fonts and stuff on phones, because those are such simple adaptations that can make people so much more functional in the world.
Yeah, absolutely. And honestly, I don't know if I should say this, but I wouldn't say I'm the most technologically inclined. I mean,
Yeah.
I can do it, but it's not like always my expert area. And it's actually been really great in having to kind of push me, because that's something that has not stayed static at all. And I'm sure
Right.
all OTs would say the same, is that we have to stay up on our game as to what is available. And while yes, I work with older adults, it doesn't mean a lot of them are embracing technology and they have it. And so they might not be super comfortable with it, but they want to learn, they want to try it. And so it's so important that we know what's available and what's going on, and be able to give them tips and strategies. I would also say too, just to give a nod to my neuropopulation, another
Yeah.
really great app that I use. So if somebody does have a smartphone, or it's really nice if someone does have a tablet, if the bigger screen, but it's called the a visual attention therapy app. And that's a great one for people who have had, for example, the hemianopsia and are having some difficulty scanning. It's an app that can actually provide them with exercises on their own, and it can provide, if it's like left or right, like a blinking line on either side to help direct their attention to where they should be scanning towards. And it's nice because it's like errorless training. So if a person misses something, it's going to tell them and make a sound. Whereas in the past, before we had those things, sometimes I would send people home and I would kind of hope their exercise, at least if they were doing it alone, they didn't have feedback. They could just be missing stuff
Right.
all the time, and
Right.
it maybe wasn't as beneficial. So I've been using, that app quite a bit. There's a free version. It's fairly limited. So I do usually recommend, it's probably like $10, $12 for somebody to purchase. And you can also grade it, make it more difficult, make it easier. So that's another good one.
And so many of our folks, they're willing to invest
Mhm.
if you make a strong recommendation, and especially those folks with the neural population that really are hoping for remediation. I think that's a great recommendation. And yeah, I totally, coming from a neuro background, I totally understand that. Like, well, sometimes it's even hard for me to give feedback and for me to recognize, like, are they scanning all the way over? So I think that's a really nice
Yeah.
opportunity.
I really, that app I've noticed more recently, in the last year or so, and it's been really helpful for me. So I would highly recommend it, for anyone who is working in that setting, to take a look and download it and give it a try.
Awesome. Thank you. So I was wondering, if you talked a lot about your evaluation process, which was super helpful, and you talked about using the self-report assessment of functional visual performance.
Yeah.
So I was wondering if that could be used as an outcome measure, or how you measure change in your clients.
Mhm. Yep, certainly can use that as an outcome measure. I also we'll use that data I said about kind of gathering their baseline ability for reading. So if I do have a patient or a client that is, does benefit from magnification, so to speak, what were they doing when they started with me? And then say we've prescribed a 5x handheld magnifier. What print size are they now reading after OT intervention? And so having that documented, that can show really, good change as to how they're doing. Those, again, the BIVABA, those scanning exercises are certainly great ways to show outcomes and improvement. The eccentric viewing also is a lot of paper-based exercises, and those can be adjusted by print size as well. So again, when I'm starting out with somebody, what are they able to see before eccentric viewing, and then however long we work together, sort of where are they at discharge? Is it smaller prints or whatnot? So those can be some ways that I can measure outcomes. And then also just documenting if somebody came in unable to use the phone, and they showed that to me through observation, but now at the end we have them using Siri, for example, or maybe on a larger button phone, and they can dial again. That would also show those improvements.
Yeah, absolutely. Just demonstrating that functional change.
Mm-hmm.
That's what we really want in the long run.
Exactly. Yes.
What are some of the other professionals that you might collaborate with?
Yeah, lots. A lot of them obviously based on, I said, the Lighthouse, I do have a kind of a whole team around me, which is wonderful. So optometrists are definitely one of the main professionals that I do collaborate with, because they're often the ones that might be referring to me. And so we want to, keep up together on how progress is going. And it maybe I show the patient something and they have difficulty with the equipment. I can go back to the optometrist and maybe say, hey, we want to tweak that, maybe try a different design, style of magnifier, what would be appropriate. I also work obviously with a psychologist a lot. One I haven't really talked about that's important are orientation and mobility specialists. So that is another big referral that I'm making for individuals who are interested in learning how to potentially use a long white cane or just improve more of their community mobility. So using public transportation, or crossing a street safely, being able to navigate curb cuts or things like that, that really starts to move outside of what an occupational therapist's role would be. And so I can make referrals to an O&M, as we call them, who could then do an evaluation, figure out what size cane they need, and then implement any of that additional training that they need. Social worker might be another professional that I interact with, technology specialists, other OTs. I just to kind of go back to your point of saying I do have OTs that might work at, for example, Shirley Ryan, or just other, I've had home health OTs or OTs from Trilogy in a mental health setting reach out to me and say, hey, I have somebody with a visual impairment that we might be discharging or I'm going to continue to work with. And I just maybe want to make sure I'm, trying to cover all the bases here. How can I help, or how can I refer? So that's definitely another group that I would collaborate with as well, which is always fun.
That's great. I think that's whenever we can collaborate with each other and support each other, I think that's super helpful. Yeah. And then also knowing when to refer out, right? Like you were saying, like the role with orientation and mobility, like we're not trained on how to use a white cane or what the right length is. So I think that also using those other resources that we have available is so important to make sure that the client gets everything that they need.
Exactly.
And that being said, do you have a particular success story you'd like to share with us today?
Yeah. I mean, I know lots of great stories, obviously, when you work for so long, and I know you have it too. You just have so many people that you feel just really connected with and touched by whatever they went through and how they were hopefully able to finish up their therapy. But one I thought that might be nice to share is kind of relevant to the times. And it was somebody that kind of got caught up in COVID and the pandemic and everything that was going on. And she was seen by our optometrist like right before everything exploded. And so she had gotten the referral to OT, but I was not able to see her in time. And then there was a period of time where I wasn't really seeing any patients. The Lighthouse was actually closed. And so I was trying to kind of figure out how can I continue to work with people in the midst of what we don't know what this time frame is going to be. And so the answer really was, as you can imagine, was figuring out telehealth.
Right, right. Which is got an even bigger challenge when your folks may not
Yes,
be able to see you on the screen.
exactly. So I am going to be completely transparent. I was very nervous. And I think that I know I'm sure this is going to resonate with some OTs who are
Yes,
listening, is that of course we're problem solvers, of course we're flexible, we're creative, but that doesn't mean that things still don't throw us for a loop and we're not
absolutely.
sure maybe how it's going to go. And I'm thinking, yes, my patients are visually impaired, they tend to be older, so technology is not always the easiest. So saying let's set up a Zoom is not, that's a lot for some people. And
Right.
so how am I going to do this? So bring to my story here. I This woman, she's 86 years old, macular degeneration, living alone in a very big house, and really had minimal support system. Some children in the area, but just not super supportive to begin with. And then COVID made it even harder because
Yeah.
even people who do have supports weren't having that physical support of maybe somebody coming in to do things because of the restrictions. So she was so anxious for OT and just wanted to, be able to connect and start working on things. So we ended up doing 2 telehealth sessions. One was the eval, and then we did a follow-up. And I really was pleasantly surprised with how well telehealth went. So I kind of went in very nervous, unsure if I felt like I could be as effective. And it was a huge learning lesson for me,
Yeah.
to be honest, because I realized how much we could talk about, how much I could still gather so much of that semi-structured interview. Yes, I maybe couldn't do all the things I would do as easily, but she had a camera. So she was able to like flip it around and be like, this is the layout, and I could see like what lighting we were working with, what was happening in the home, at least get a sense of the space. So it actually worked pretty well. And then we were able to ship a few things to her based on our conversation. Then we followed back up and we kind of went through her little package together, and I explained things. And then ultimately I was able to get into her home once things, I wouldn't say they settled down, but we knew how better to handle and
Right.
PPE and how to have an appointment that would feel safe and comfortable for us both. And from there, we were just able to do a whole bunch of things that were really great, like a bump dots. I'm sure a lot of OTs know about those, but being able to go through and mark her appliances tactily in her kitchen. She was having trouble. She wanted to be able to operate her water heater. She had all these specific things. That doesn't come up that often, but it was great to be able to help her with that. She had some computer stuff going on, so we got on and I showed her just built-in accessibility on her computer. Got her back up and running with some of her bill pay. We did some lighting, and she did well with magnification. So it was a really a neat experience for me because I had never really done a lot of telehealth at that point, and I was really thankful that we didn't have this approach of like, well, we're just gonna wait and ride this thing out. I mean, the telehealth was so important because she would have been waiting for months
Right.
and for to see me, and I realized that we really can still provide really good care in that setting when it's needed. And so it was really great. Yeah.
That's just such a
Yeah.
great story. I do think that, that was an incredibly stressful time for healthcare. And you're right. Like, yes, our job is to be flexible, but when you're thrown for a loop, almost overnight, like that's a high stress situation. And I
Mhm.
I think that also it's a great example of how kind of a hybrid model can be really helpful. Like maybe to see the home over a telehealth visit before you go in, so
Mhm.
you know some more of the things that you want to bring to the visit or that you want to address in your limited time in
Absolutely.
their home is that's a really nice opportunity.
Yeah, it really was. And I actually feel that I can do a lot of, like, most people could be evaluated over telehealth. Like ultimately sometimes there are pieces when it's like I need help on my computer, I almost need to, touch their iPhone to do certain things, or
Right.
Android. But there is a lot, there's a lot of like information, especially for a low vision population, like telling them about audiobooks. I could go ahead and get somebody signed up with audiobooks completely via telehealth. So it's like you could still get a lot done. And I think for me, it was also just a good reminder of how important OT is just in general, not just low vision. It was that I remember feeling like I have to find a way to be able to continue to work with my patients because this is horribly isolating. And going through a vision impairment is really, really scary for people. I mean, because a lot of them know it may progress. And then when you add on like they can't see anybody and they don't have the supports they
Yes.
had. I mean, it was a really fragile time, especially then. And so it just really hit home for me, how important we are in our role. And so I knew that, but it's sometimes good to have those little
Mhm.
reminders, especially as you've been working longer.
Yeah, absolutely. And to recognize that we can use this technology to really reach out to some of our clients, which we've been saying for years, but I guess it was sort of good to be forced into pushing ourselves through this because I know there are folks they live in Chicago, but it's so hard for them to get out of their home when it's not COVID. If we can reach out to them now that we're more versed in this technology, it's
And to your
great.
point too, low vision patients, transportation is a huge issue, COVID or not. Most of them
Right.
can't drive. And so they're very much dependent on somebody being available to get them if I'm seeing them in the clinic or things like that. So I think I agree with you. I think it's a blessing in its own way because it was like the push that really all healthcare providers needed. We were like, we need to implement and really plan and really roll this out. And we just kind of
Right.
had to
Just
go.
do it. You've been
Yeah.
talking about
And
telehealth for 10 years.
yeah,
Let's just do it.
right. And yeah, it wasn't always perfect. And I mean, I learned better ways to do things as I went, but I think that is where the beauty of like we do have that training. So we are able to pivot and we are able to problem solve, but just needed a bit of a nudge.
Yes, yes, for sure. Well, this has been all really wonderful. I thank you so much for it. And to finish up, I just always like to remind everyone that at the MoxieOT podcast, we want to make sure we provide an opportunity for our listeners to increase their Moxie. So, if a clinician wanted to know more about OT's role in low vision, what resources might you recommend to them?
Yeah, so some of the things I did just mention in terms of what I really relied on in the beginning, there's a lot of good stuff AOTA also has. Like you could go on there and look up like the practice area of low vision. And I know they've also put out um, a lot of books and different things that you could read or catch up on. So that would be one that's good. I do really like the visionaware.org website, as well as I really would recommend there's another great website on there called the Hadley Institute for the Blind and Visually Impaired. And over the years, their website it has gotten better and better just in terms of what's available. And yeah,
It's
you're
really cool.
yeah, they have some really great they have like sections on technology and training specifically on just even like how to use Siri, and that can be broken down into all these smaller components for people who are visually impaired. So I go there even now because they just have different topics. So I would definitely recommend all of that, and those are free resources as well. And then there's a lot of different courses. So like I said, conferences like Envision and just other things that you might see out there. I mean, I know I get like CEs and things for vision stuff all the time. So if that's something that's of interest, try to take advantage of that. And at least right now, a lot of those things are from home. So you don't have to worry about travel
It
and
is really
hotels.
nice,
I feel like that
actually.
used to be,
We can get so
I
much
know,
more now from home.
way more cost effective
Yes, for sure.
and just easier. So those would be some ideas to start off with. And
Thank
to
you
reach
so
out
much,
to OTs
Laura.
who do it. I'm always like, I appreciate when if an OT reaches out to me, and I do get emails or calls from people, asking questions. I'm always more than happy to talk and give my 2 cents or thoughts if I can be helpful in any way.
Yes, I think, I think being willing to put ourselves out there and reach out to other OTs for help is really important. And sometimes that maybe we're a little timid to do sometimes. So I think that's a helpful reminder. Well, Laura, thank you so much for joining us today on the Moxie OT podcast. It's just been a pleasure talking to you.
Thank you so much. This was fun.
Thanks for joining us for this great conversation with Laura about OT's role in low vision therapy. As I explored the topic of low vision OT for this episode, one article I found helpful explored the perceptions of individuals with low vision regarding home safety. Their findings included 5 categories: lighting, contrast, visual distractions, glare, and compensatory strategies. While many of us might not work in a low vision clinic like Laura, many of us will work with older adults with vision loss, often as a secondary condition. Knowing how vision affects occupational performance is an important part of our skill set. As Laura discussed, the Envision Conference is a great opportunity for us to network with other OTs and professionals that work in low vision, as well as a great opportunity to participate in continuing education. The revised self-report assessment of functional visual performance is a great tool for measuring your client's self-perception of their ADL performance. When working with neuro clients, I find it very helpful to use the BIVABA, or Brain Injury Visual Assessment Battery for adults. This can be a helpful screen to see if your clients with neurological diagnoses are experiencing visual impairments, or a good assessment tool when you need to further assess a client's visual abilities. While you're checking out the BIVABA, I also recommend you explore all of the resources on the Visibilities website. We'll have links to all of these resources, as well as the many resources Laura mentioned in our podcast, on our website. If you want to be a part of the conversation, leave us your email address at moxieot.com. We're on all of your favorite social media channels as well. The Moxie OT podcast was recorded in our home in the Avondale neighborhood of Chicago. This episode was produced by Brian Zira. Our intro music is courtesy of 13 Taco Studio. Technical assistance was provided by our dog Grody. Thanks for joining us. We'll see you next time.